Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I am thrilled to be joined by Dr. Stasha Gominak. Dr. Gominak is a neurologist who completed her neurology training at Mass General in Boston. From 1991 to 2004, she practiced as a general neurologist in the San Francisco Bay Area before moving to Texas, where she began to concentrate on treating neurological illness by improving sleep. She published a pivotal article in 2012 proposing that the global struggle with worsening sleep was linked to reduced sun exposure. And in 2016, she followed with a second article linking the change in intestinal microbiome to the epidemic of poor sleep. She currently divides her time between helping individuals through virtual coaching sessions and teaching clinicians and coaches how to use the protocols she's developed to improve their patients' health and well-being. Stasha and I have a fascinating discussion about sleep and sleep medicine, vitamins and vitamin supplementation, exposure to sunlight, diet, and gut microbiome, and the role that all of these factors play in our overall health and wellness. She is a great example of a physician who practices what Peter Attia refers to as Medicine 3.0, as she takes a proactive, holistic approach to patient care instead of the traditional, reactive, siloed, symptom-based care we have become so accustomed to. I assure you that this conversation will challenge and hopefully change the way you think about living a healthy life. So without further ado, let's get on to today's episode with Dr. Stasha Gominak. Enjoy the show, everybody. Welcome to the Doc Podcast, Stasha.
Thanks for asking me, Dr. Mike.
Oh, okay. Mike, please. It's really a pleasure to have you on. You are an amazing wealth of knowledge in areas of medicine where I really feel strongly we need to be going, but haven't been for the amount of time that potentially we should have been. Although in listening to a lot of your discussions with others prior to having you on my show and researching some of your material, there are a lot of parallels because I'd say the groundwork has been laid for a lot of what you're doing and talking about back in the 80s and many decades ago. And orthodontics is the same way. And we can even talk about that a little bit throughout the show. But before we get going into what all of that is and what you're doing and what you're so passionate about, tell us how you got to be the Stasha Gominak that you are today.
I'm a retired neurologist. I love neurology. I still do. I really like biochemistry. And I happened to move to Texas mid-career about now 20 years ago. And I was taking care of a lot of daily headache patients. And those patients are majority young, healthy women who've had a couple of kids or not. Mm-hmm. And we have very, very poor treatment for them. And you'll see them too, because they have pain in their head. And yes, and they're trying to get to what the answer is. And orthodontists have answers for them too. And it's not that each one of us has our own separate way to look at these things, but it has been my experience that multiple approaches really has better success. And so eventually one of my patients asked for a sleep study. I had no experience with sleep at all. I was not trained in that. She got better with a CPAP device and she was not overweight. She did not have the physiognomy that we would expect because we were told that fat necks in males, older males, was where sleep apnea was. And then she put on this weird torture device at night and her headaches went away. And because I had already been treating headache patients for 20 years, I knew that most of our interventions were temporary at best. And it's very frustrating because you want them to get better. It's a terrible thing to have because everybody says you look fine and you're really not fine. And it's a terrible way to live. And
people start to think these people are crazy. There's
no question that we're often told they're crazy. Yeah. Their family thinks they're crazy because they don't want to do anything and they don't feel well enough to do anything. And it's terrible. So anything that might help those patients. So one of the things that was really pivotal was I was using CPAP because that's all we had. And CPAP is not a drug. It only pushes air through the nose. It keeps the airway open. But the only thing I could figure was somehow this device, which is not going to have placebo effect, is allowing my patients to stay in deeper sleep longer while they're paralyzed. And that piece was really important. They are paralyzed during sleep. That means the reason why we talk about sleep apnea is because there's something special happening in that phase. So we're going to talk about the airway, I imagine, and the airway and making the airway patent and able to stay open while you're lying down is a really important issue. But then there's something special that happens once you fall asleep. So those ideas were given to me in a time when I had sleeping pills and CPAP, and I really didn't expect CPAP to do anything for headaches. And a lot of people, it made them a lot better. That then claims to me, okay, well, there's something happening during the sleep that can fix this person. And why did most of my patients not have sleep apnea? And what do I do then? I have so little in the way of things to intervene. So that gives you this feeling of frustration for the patient and for me. And then that means a willingness to look around, which is...
And so when you say they didn't have sleep apnea, they were having polysomnography or sleep studies done, coming back as not being significant sufferers of sleep apnea in the traditional sense as we're looking at it diagnostically, the quote unquote gold standard of that. But yet they were having relief from some of their symptoms and comorbidities with CPAP.
Well, some of them would use CPAP. So what I had at the beginning was a woman who had sleep apnea. She put on a CPAP device and she got better. And then I did hundreds of sleep studies and most of them didn't have sleep apnea. And at the beginning, I was just struggling with, well, why not? And I was not reading through the whole study because I was just looking for sleep apnea. But when 5 out of 6 don't have sleep apnea, then you're stuck. And then finally, I had this very important set of conversations with the pulmonologist who was reading this, who said, well, I don't know if you've noticed this, but a lot of your patients, which, by the way, are very different than the usual patients that are sent to us, all these young, healthy females. And he said, I've noticed that there's a consistent finding with your patients. Their REM sleep is not normal. It's either very delayed, they have very much less than they need, or they have REM-related apnea. And then I was, wait, what is REM-related apnea? Why would we only stop breathing in REM? And he said, we get the most paralyzed of all in REM. That conversation led to all sorts of other thoughts. And then I began to read the whole study. And actually, a layperson can read the whole study. They give you the normals right next to it. So it says, hey, you should have 2 hours of rapid eye movement sleep. Oh, you only have 30 minutes. And then every 5 minutes during that 30 minutes, you're waking to a lighter phase of sleep because you're trying to take a breath and you cannot, and your airway collapses. You don't have to have a lot of education to actually be able to read that, but I had not gone into the report itself. Then the next question is, well, Chuck, why isn't that on the front page? Why isn't that on my report? Why isn't there no significant apnea? When this person only has a half an hour of something that normal people need 2 hours of every night. And, oh, by the way, why do they always say the same thing? I'm in a terrible mood. I can't remember anything. And I feel tired. All of them say the same thing. They all say, oh, I wake up at 3 a.m. and I can't go back to sleep. And is there a general age range of these patients that you're describing that you're seeing? At the beginning, it's some teenagers, women in their 20s, 30s, 40s, and then there's a big bump in daily headache around menopause. Okay. At the beginning, I got a bunch of women who are otherwise healthy, which is really important because then you can't point to a medicine, another disease. You're just left with, well, wait, like, especially if 50% of them are young, in their 30s and they don't have anything else wrong with them. And they say things like, oh, I just ran a marathon last week. I'm a triathlete. Oh, I've just done paleo and blah, blah, blah. They're not stupid. They know they feel terrible, and they know that's relatively recently since they've had their kids. So they were normal people before, And now having the second kid, everything has changed. That really puts it in a different setting. Like you can't use genetics to explain that. Something else is going on. And all these normal people are having these really bad outcomes. And then pretty soon, within the first year, I'm starting to do sleep studies and anybody will let me. Because now that I know that how to look for things that are abnormal in the bulk of the sleep study itself, then I wonder, wait, migraine is a genetic disorder where you inherit a gene, but so is epilepsy, so is Parkinson's disease, so is tremor, so is all these other things that I'm seeing people for. And if this can heal someone, why don't we even treat sleep as though it is really the power behind healing? I know I'm not healing. I know I'm fiddling around with medicines. I know that I'm sending people for surgical interventions that might help, but I watch what happens after the surgery. The body is knitting together. That means it has to be happening at a certain time. And all of a sudden, I see the world through a totally different lens. We are standing at the bedside while the body heals itself. And then every experiment that you do in animals or in a petri dish in science, you have to think of it within the context of that particular cyclic repair system that I've been thinking that I'm helping my patient with. It might be happening only at a certain time of the night. Well, what if that's the case? I should always be treating sleep in everyone. So within a relatively short period of time, all the people with strokes that I see on the weekends, all the people with very severe neurologic problems that I'm having to get immunosuppressive drugs to because they have autoimmune diseases, now I'm looking for sleep disorders in everybody. And the results were relatively uniform. It's not that I am able to publish that data because I'm not a scientist. I am a clinician. But I began to notice that other people who had other things wrong with them, like strokes, my stroke patients who were able to tolerate CPAP would get better faster. And things that would happen with this weird torture device, their cholesterol would go down. They could come off 2 of their blood pressure medicines. There was so much what we were doing for treatment of a routine medical problem that wasn't in neurology that would actually get better as soon as they put the CPAP on. So for 5 years, I'm looking at that thinking, this is an epidemic. Every single person who comes to see me, even 5, 10-year-olds, I send them for a sleep study and it's abnormal. That means we're looking at this whole problem in the wrong way. That 10-year-old,
but maybe not with an AHI of whatever it needs to be to label them with apnea, right? Or sleep apnea, right?
Well, most of my patients did not have apnea.
Yeah.
And therefore, what I'm now focusing on is how much sleep do they have in these deeper phases? How much deep sleep do they have? How much deep sleep does a 10-year-old need? How much REM sleep do they have? How interrupted is it? And really, I can then state, if this 10-year-old goes to sleep at 11 and gets up at 6 a.m. to go to school, I don't care what the sleep study shows, that kid's being shorted on their sleep because they can't go to sleep at the right time. That means when you look at it in a totally different way, that's the first question you should always have. And the other thing I learned right off the bat was, if you say, how's your sleep? Most people say fine. 10-year-olds have no experience in what their sleep should be like except their own sleep. And then most of us have no experience except whatever happens in our family. And that means if every kid has abnormal sleep now because it's an epidemic, and you're standing at the vegetable counter talking to your friend, and her kids are running around in the store, and you say, my kid wakes up every night and climbs into our bed and complains of his leg pain, and she says, my kids do too, that's the new normal. You would, and the doctors don't know the difference either. Because I was born way before the B and D, what we're going to talk about later, deficiency states existed, I do have a set of experiences, not only for myself, but my mom's generation, my grandparents' generation, of what their sleep was like. What was it like to bring home a baby? What was the baby's sleep like? What do we think was normal or abnormal? And that would have been in the 60s and 70s. So from my point of view, the things that I was seeing in epidemic proportions now in the early 2000s were not normal when I was in school, let's say. Mm-hmm. So in the background, I'm watching what happens with these CPAP devices that are not drugs. And if you have a success, the success is, unfortunately, short, just like the drugs. It's like, oh, I've been using my CPAP for 4 years. The first 2 years were great. Now I'm back on my blood pressure medicines, back on my diabetes medicines. That means there's something else in the background. We're not treating. There's a disease in the background. So that CPAP experience was really important. Like most of my younger patients who were there for things that we would consider like migraine, it's disabling, but it doesn't look it. It's not like having cancer or something that's about to kill you. That means that all of these things that we have genetic weaknesses for. So I could say, okay, her mom had migraine and her aunt had migraine and so did her grandmother, but why didn't she have migraine until after her second kid? That means these are now epigenetic things. So genetics has limited us to saying, bad luck for you. Your mom had migraine. See you later. That's not what I want as a patient. I want something that's going to change things. When if you understand what epigenetic means, it's, anything other than genetics. And I say, do you think perhaps sleeping better is something that could make your body's repair systems better? I think most lay people would go, yeah, I know what it feels like to be tired and not sleep well. We've all had that experience. That means if we can somehow intervene into something as important as sleep. And the weird part for me still is, I'm 20 years into this, and I'm still going to the sleep meetings. And the majority of the reports that I see in the posters and on the platform sessions are not, I listen to 40 of my patients in my office, and here's what they tell me about their sleep. And here's what their sleep studies look like. Wouldn't we want to know why they don't have any REM sleep? And the reason why we don't talk about it is nobody has a ready answer. But a clinical observation in medicine that is still slightly a problem in dentistry, but nowhere near as much, because you guys have these before and after pictures. One of the reasons why you're here asking me is if you have long enough experience with procedures into the airway, into the mouth, and you have a few people who do a little bit better, but not as well as most of them, and you start to be curious about that. Well, what's different here? Why?
Yes.
Is that question that leaves you open to being interested in, what else could be going on? And right. I really feel like that has played understanding that has played a huge role in why dental sleep is interested in what I have to say. Medicine is not curious. I don't understand that, but they're just not curious enough. And I'll let you ask anything else that comes up with that.
Yeah, I appreciate you painting that picture and providing that color for that, because I appreciate the kind words and support on the dental profession. And I agree. We have a lot of people in the dental profession that are thinking that way. Sadly, there are a lot that, and especially in the orthodontic arena, and not to hate on the orthodontists, I am one of them, so I can speak to it with openness and honesty. We don't really accept a lot of it in the orthodontic profession. We tend to sound more like what you describe the physicians as, which is, Peter Attia calls it medicine 2.0. I actually started calling it ortho 2.0, treating the teeth, looking at the teeth. It's unbelievable to me. We get no sleep education in our dental or orthodontic training beyond dental school. And those of us who have gone down this path, exactly what you said, and I give you such credit for that, for thinking more about the problem. And I say to people all the time, and I love that you highlighted the pictures. When I teach and when I coach, I tell people, you have to take outstanding diagnostic records in the beginning, middle if needed, and end, and then not just take them and throw them in the chart, but look at them, sit with them, because that's when you're going to look and say, gosh, I did the same thing I did on this group of 10 kids as this kid. And it didn't work. Mom is still saying they're snoring. Mom is still saying they're mouth breathing. They're still having behavioral difficulties. The other kids, within like 3 months, the parents are in here in tears, like, oh my God, you've changed my child's life. And I've gotten them to the ENT, and they've gone to the allergist, and maybe they've even gone to the sleep physician and myofunctional therapist, whatever it might be. What is going on? And those deep thought processes that I really encourage everyone to go through. Clearly you did. It's what brought me on this journey, where what started to tell me there's more going on here and we don't have all the answers. And I think part of the problem is, as physicians, dentists, we don't like not having answers. Like,
yes.
We're the smart ones. We're supposed to be the ones that figure everything out. Patients come to us for our advice and expertise. It's not very comfortable to say, Mom, I'm not really sure why this didn't work for your daughter. So as you were piecing this together and you were starting to put these puzzle pieces together and take all this information and looking at what works and what doesn't, were there aha moments? Like, I know you said one of them was the REM sleep being much less. And again, kudos to you for going deeper into these sleep studies and looking into them in greater detail and not just accepting the, oh, nope, they're fine. They don't have sleep apnea. Were there other things that you saw that just started to add up when you looked critically? Like, gosh, this is getting to be a trend or at least a pattern.
Yes. What happened was, at the end of the almost the 5th year, one of my patients, who was a beautiful 18-year-old about to go to college, came in for daily headache, and her sleep study, everybody has a sleep study who sees me. And by the way, my colleagues thought I had lost my mind. And they just wouldn't listen. Okay?
I understand what that's like.
Yes. Everybody I saw in the hospital for serious bad stuff, they all got sleep studies. After a while, it wasn't just the elderly males. Mm-hmm. This young girl's sleep study was horrendous. She had no deep sleep. She would wake up 35 times an hour. And at the time, I had absolutely no education in dental sleep because, as you've heard, I'm just a dentist. There is this caste system that wasn't obvious to me until I started to lecture with dentists, that is the arrogance of physicians, as though there's something different with the people who take care of my patients' teeth. That is ridiculous. So, and it
even happens, and sorry to interrupt you, Stasha, it even happens within dentistry.
Of course.
I've been, my orthodontic colleagues, I've been very hard on them. There's a big thing. You'll see it all the time on our online groups. Like, who are these non-orthodontists recommending airway related treatments for our patients? It is, like you said, this caste system. It says, it
happens in all human groups.
Yeah.
No matter where we go.
Thank you. Yeah. Yep.
And it keeps us, the important part is, if you really want to take care of patients, at least you can be aware of that caste system and you can prepare yourself to get rid of it, because your patients are going to come in and tell you things that you need to know, and you'll think they're just a patient. And getting past that point where you're not embarrassed to say, I don't know, and what do you think? And frankly, anybody who wants to can get online and sort of learn how to become an orthodontist. They won't have the hand experience, but they can sure learn how to be a doctor. They don't have to go to a medical school to be able to use the library anymore. They can learn so much more about their disease than I do, because they're focused on what they're feeling. So as clinicians, we are shorting ourselves with that attitude. So, and that happened to me first when I was working in Silicon Valley, and all my patients were software engineers, and they'd come in with, literature searches, and I was like,
what's this?
How'd
you know that?
I'm never going to keep up with these guys, so I better just change my whole view. And then as we got into sleep, none of us in the room, none of the patients, I didn't know what to do. They didn't know what to do. They'd go to their sleep doctor, quote unquote, and they'd see a nurse practitioner, and she'd say, well, you use this or die. Okay. She didn't have anything intelligent to say about the fact that they were struggling in some way. And I started to learn about that. And I was thinking, this is really weird. They won't listen to the fact that the patient says, I wake up and my mask is off. I think that I take it off around 3 a.m. That's what my wife said. And there's this odd 3 a.m. what's with 3 a.m.? Because all my headache patients say I wake up at 3 a.m. with a headache, or I wake up at 3 a.m. and I can't go back to sleep. And finally, I get into, okay, what's happening at 3 a.m.? That's when we transition into REM sleep and we get the most paralyzed of all, including the airway. Oh, the first question should be, what? How do we live through that? How do we get paralyzed and live through it? So I want to refer back now to that sleep study on that 18-year-old. What she had was waking up 35 times an hour. And the reason why I said I didn't have any education at dental sleep is there are all sorts of subgroups that are recognized as being respiratory related. But she didn't have any respiratory related stops to her sleep phase. She would go from a phase 2 light sleep, try to go into deep. This is my imagination of what's happening. And then she'd wake to light. Try and go into wake to light. So she would wake up to light sleep. She never woke to consciousness. When I asked her, how's your sleep? She said, fine. She said,
so she wasn't. Okay, great. I'm glad you said, okay, interesting. So she's not even aware. Okay.
She is not aware that there's anything wrong with her sleep at all. She just feels tired. And that is a subset of teenagers. They're just tired all the time and they can sleep. So looking at her sleep study, she's not someone if she said, I sleep fine, I don't snore, you wouldn't send her for a sleep study. There'd be no reason to. So looking at her sleep study, I thought, oh my God, in 10 years, she's going to be seeing me in the hospital with a stroke. I have 25-year-olds who have strokes and no apparent reason. So she turned out to have a B12 deficiency that was quite profound. And the only reason why I did that, I've been successfully trained away from vitamins by medical school. And she said, I'm really tired. And, she said, my headaches are better after I gave her a medicine. So she didn't have sleep apnea, so she doesn't qualify for CPAP. But she had a preventative medicine that worked for her. But she's still so tired. So I did thyroid and B12, and the B12 was profoundly low. And because of the state of the internet, even though we make jokes about Dr. Google, I walk out of the room and I look for B12 on Google instead of in a medical textbook. And it says chronic fatigue and daily headache. And I was like, I've never done a B12 level in a headache patient in the whole time I've been practicing. And when I went back to the neurology literature, it's not listed as what you should do for daily headache. It's listed under B12 deficiency, which is conceivably something totally different. So that because of the level of frustration there, 5 years of not being able to help people, knowing that these medicines, no matter what it's called, whether it's a tricyclic antidepressant or a blood pressure medicine or a sleeping pill, the only thing that really works are things that affect their sleep. And I become clear on that now. The medicines I've used for 20 years before that really were helping the sleep were helping the headaches, but they don't last either. And that means I'm looking for why on earth would this normal person, so then I start giving B12 injections. I was thrilled by the fact that there were already several articles about B12 and sleep. So why didn't anybody put that in the treatment of headache? Because there were no connection between sleep disorders and headache at the time. And even now, there's more and more literature about that. There's clear epidemiologic match between sleep disorders and daily headache. So I started to use B12 injections. I wasn't giving the injections myself. I would send them back to the internist, but they would come back to me and say, wow, those shots, I had 2 good nights and then 28 bad ones. That means there's this interesting concept. This chemical has power in sleep. And I don't know how, I don't know why, but I'm reading a lot of anatomy texts. I'm reading about weird experiments where they have this hair-like electrode into a specific cell in the brainstem. So I learned the anatomy of where do we get paralyzed from. Who knows about that? When did we learn about it? Who's studying that? And there are weird experiments because I have no place else to look. There's no one publishing this. There are sleep study centers popping up all over the world. And every place that they pop up, the people have abnormal sleep. Like 90% of the sleep studies are abnormal, if you include what's in the bulk of the actual study, not in the report itself. And nobody's writing what to do. Nobody's saying why all these young, healthy females should have terrible sleep like this. But I know that it wasn't like this when I was in high school and even in medical school. This was not an epidemic then. So there's a timing issue around it. And most of what we're being fed even now is toxins. And that's the way I was thinking too. There must be chemicals in our environment because that's what we've been fed. And so she has B12 injections. She gets a little bit better. The patients start to come back and say, I'm giving my injections once a week. And what I didn't realize was Medicare has stopped paying for injections once a month at the doctor's office. So they're giving them the actual bottle and the syringes. And now they come back and say, I'm giving it once a week because I feel so much better. And then I start to realize, wait, this is weird. This is a chemical that should be there every day. And in the meantime, I have another patient who, in true irony, runs a sleep center. She's on disability because she's so sick. And she has so many things wrong with her. She's a pulmonologist who runs a sleep study center. And she says to me, I saw my primary physician. She checked my vitamin D level. It was low. She gave me vitamin D. And my wrist pain went away. And I don't care anything about vitamin D. It's another thing I know nothing about. So I just test the vitamin D level. I'm testing the B12. And everybody who's had a sleep study, who sees me for anything, where I'm thinking, if this could be a deficiency state where we could give back something that would fix this would be miraculous because this is so common. So
did you know why at this point they were deficient? Any insight into that at this point?
Yeah, I didn't care about vitamin D.
Yeah.
Nor did I care about
or in B. Like when they came back with B12, were you seeing patterns in them, or were there certain things you're saying, yeah, fits a specific phenotype, or was it more just kind of random presentation that you were wading your way through?
Because you're describing what you're doing when you look at your patients.
Thank you.
Every single one of them has a certain history, a certain presentation. And the natural thing for the clinician to do is, I want to do this and have success with all of them. What are the distinguishing features of this person before, during, and after? Why was it so? This is the value of a clinical medicine, which has been greatly devalued. We are on the front line with the patient. So your questions are appropriate. I put in a vitamin D level because I'm drawing blood, which I've never done on my daily headache sufferers before, because no one ever said that there was a link. So I'm drawing blood, and for 4 months, September through December, I draw blood on everybody who comes in who I have a sleep study on, and I do a D and a B12. And instead of sending everyone off for CPAP and a sleep study, because I'm like, if I could use B12 instead of doing CPAP, I would do that. So I do all those labs, and by the second month, I'm sending out lab slips, 14 a day, saying your vitamin D is low, take 1,000 IUs of vitamin D. I know nothing about it. It doesn't have any relevance for me, but I'm doing what I think is the right thing. And only a few of them have B12 deficiency, maybe a quarter, the really, really sick ones. And it doesn't matter what age. They can be B12 deficient in young age too. And I still don't have a context for why they would be B12 deficient, but so I'm excited about this. And then 2 guys come in December saying the same thing within 1 week, within days of each other. Oh, I'm wearing my CPAP. My wife can attest that I wear it every single night. You promised me that it would take my headaches away, but it didn't. And I'm like, oh, bummer. And no, listen to this. You sent me that note about my vitamin D being low. I went on and bought the vitamin D. I started taking it. And about 3 weeks later, my sleep got better and my headaches went away. 2 guys tell me the same thing. And for the first time, I think, whoa. Everybody's got a low D. And it was in September through December, where in Texas, you would think that D would be the highest of the whole year. So mine was 35, which said normal. And I was like, well, I'm not taking any D. I wonder, what is all this about? So that was December of 2009. And since then, I say if I really knew what I was getting into, I probably wouldn't have been afraid. But I was completely naive. Because vitamin D is now so politicized within medicine. It is really weird. It is a very weird and uncomfortable experience for someone who reveres medicine. I love taking care of patients. That is where I've been for my whole career. But medicine with a capital M has really betrayed us. in their way of studying the science that's in their own journals.
Yes. Oh my gosh. The parallels with orthodontics as you're speaking. Oh my gosh.
I'm in 4 teeth taken out. I have a teeny tiny airway. Expansion hasn't done jack for me. Why? Because my palate is so small. And I also have a very narrow nose. I learned all these things and I'm like, wait, my mother spent, how many thousands of dollars she didn't have to have those teeth taken out. And to realize that before they started taking out the teeth, they were doing closures. They were doing expansion.
Yeah, Ricketts in the 70s knew with his quad helix and his W arch, he was trying to develop. What Ricketts was talking about airway, I mean, I go back, there's literature, I just gave a talk a few weeks ago. I was citing some of the articles from the early 1900s where physicians and dentists were both talking collaboratively. They called them rhinologists then instead of otolaryngologists. Dentists were presenting at meetings, rhinology conferences, and they were both talking about the impact of airway and mouth breathing on craniofacial and neurocognitive growth and development. I'll send them to you after. It's fascinating stuff. The intuition we had even back before we had the diagnostic abilities that we have now. I feel like we've regressed in so many ways, right? Where when you read some of this, it's literally everything that a lot of my colleagues say to me now is this new airway fad to make money. I'm like, was it new 115 years ago? Edward Engel, who's the father of modern day orthodontics, in 1907 said, of all the causes of malocclusion, mouth breathing is the most potent, constant, and most varied in its results. I mean, we knew this, so it sounds like there are a lot of parallels in
many
medicine.
Parallels. I'll tell you, once we get into the vitamin D, I'll give you a couple of parallels that are very, very similar. So I then fell into the vitamin D literature over the week of Christmas, because it was just before we broke for Christmas. I had a whole week, and I spent that week on PubMed. And now, because of this change in our ability to look at things so rapidly, at the time, there was not a single hit for vitamin D and sleep. The first article was published in January of 2010. And
when was about this? Which year Christmas was this?
When you were doing the search? 2009, just a few months later, oddly up by a guy down the way from me in Louisiana. But there were no, for those two search words. Now, if you put in vitamin D in the brain, I got into a guy named Walter Stump who had spent his entire career telling us where the vitamin D receptors were using this very special technique. And he made up a belief system. And it turns out, this already, we see through our belief system. If we have a belief system that says taking out the teeth is the right way to do it, there are too many teeth, even though humanoids have been walking around, hominids have been walking around with the same number of teeth for now we think it's 300,000 years.
Yep.
Those sorts of, you picture through an evolutionary lens, and you include all animals and you include humans. It's a really different lens. So this guy had put together a belief system, which was we have a steroid hormone made on our skin from a particular wavelength, because that wavelength is absent at the north and south during the winter. That allows us the survival advantage to either migrate or hibernate. It gives us a message that tells us what to do so we can survive. All hormones are about animal behavior. The behavior is complex. And this guy also, unfortunately, Walter had bad experience with his peers. This is a big problem right now in journals with his peers. And he was kind of dismissive and wrote a really nasty article about his peers, because his first set of articles were about estrogen receptors in the brain. And his peers said that was ridiculous and stupid. And of course, there wouldn't be estrogen receptors in the brain. Like, who were they living with if it wasn't their wife? And so he had a pretty crappy attitude, but he was also brilliant. And
reminds me a little bit of Semmelweis, the Semmelweis story. Right, of the hand washing. Yeah, go ahead.
And then he put together this picture of what it should be. By the 1980s, he's writing things like vitamin D receptors in the brain and seasonal affective disorder, vitamin D receptors in the ovaries and the fallopian tubes and infertility. vitamin D and the GI tract and reflux, vitamin D and the teeth, the core of the tooth and tooth development. He's writing all these articles. He's got hundreds of articles over the 30 years he's publishing that actually are before the vitamin D deficiency epidemic develops. So he's writing in the 80s. And it would be my claim that the D deficiency really started in the middle 80s as we started to use sunscreen and air conditioning and computers. So he has actually predicted what's going to happen in the future and then lives until. So I read all these articles over this time and I come back to work just blown away because remember how I told you I was reading those weird articles with the little hair-like electrode into a single cell where we get nervous? He has articles that show vitamin D receptors in those particular nuclei in the brainstem. I'm like, nobody even knows about this brainstem area. Nobody knows about that. How did this guy even isolate? Then he tells you that there are vitamin D receptors around the lateral ventricles that make up the blood-brain barrier. Therefore, making the claim that this was in the background for all of the neurologic illnesses where the blood-brain barrier is broken through. All the types of, this is not only central in MS, but in the peripheral system where you break down the blood-brain barrier and the immune system sneaks through, bad things happen. So every single thing that he made up. Now, if you look at it through, it's a bone vitamin, unfortunately it was named incorrectly, you won't see any of that. And even now, all the different vitamin D experts, and frankly, I don't think we have any. I have some people that I respect more than others, but what you see is they see vitamin D through their original belief system lens, and then they look for certain things. And in my view, Walter's viewpoint of this was overarching and so much more applicable to all the things that I was seeing. Because as soon as I start reading this, I think, wait a minute, what are the other diseases that these young women have when they come to see me for headache? Gallbladder disease and thyroid disease. Oh, is vitamin D involved in the bile? Yes, it turns out vitamin D is just like cholesterol because it's made from cholesterol, and they're the two emulsifiers in the bile that keep the bile acids emulsified. Therefore, you don't make stones. And why is it after they have their second child? Because every single pregnancy uses up their vitamin D, and they don't have time to get it built back up again because they don't go out in the sun. And then they have miscarriages before the next kid. But those two miscarriages actually used up their raw materials too. So I start to be able to picture things through this lens of all of reproductive health is connected to this. There are articles about the fact that when the D is low, there's another hormone called the anti-Müllerian factor that inhibits the development of the egg every month. So these women develop polycystic ovarian syndrome, which just means multiple little eggs that are trying to ovulate that are stuck in that phase. And it's about endometriosis because there's help from vitamin D in the fallopian tube that makes the egg be pushed down to the mid place. And it also prevents the endometrial tissue from going up the fallopian tube. All of these things are already written. They are not hard to find. All you have to do is say, well, I wonder if blah, 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 and put it in the search. And going back to what you had said about early development, when you just go back to the very early articles, before vitamin D was named, rickets was a disease of children. And the description is, my kid won't eat, they won't play, they cry all the time. They're basically a mess with a runny nose. They get infections more than my other kids. And in 1925, Alfred Hess is addressing the child hygiene section of his medical group and giving a lecture. And he talks about the fact that he and Dr. Unger are putting children in the tenements of New York City because he's practicing in New York where he gets to see people who are wealthy, who have summer homes, and then he gets to see the poor who are stuck in brick houses with no place to play. And Dr. Unger and I are putting them out in the sun. And for the last 200 years, we've believed that rickets had to do with sun exposure, and we've healed kids. So it's not that it's a new idea. And he talks about the fact that it's so sad that we can see that living things like plants need sunlight, and that the children are the ones that are suffering for this. I had a friend at that time who had had 5 miscarriages, finally got pregnant. Her first child did not sleep the second and third month of his life, the whole time, yelling and screaming, and everybody's about to kill themselves. And what did her pediatrician say? He's 15 now, so it's 15 years ago. You have a colicky baby.
Yeah.
That's it. And that means all of this is preventable. It's so much easier to prevent than it is to treat retrospectively.
Yes. Oh my gosh. And that's so similar to the battle we face in the orthodontic and dental world with this, getting people to realize that we can be proactive, that we can try to take steps to proactively do things for these patients. The key is, and just hearing you speak, it becomes incredibly evident, this takes time. And not only time to research it all and to expand your breadth and scope of knowledge, also time with the patient.
Yep.
You can't just throw a medication or a CPAP or whatever it is at them. And if it doesn't work, throw your hands up and kick and punt to the next specialist and say, well, that's not going to be me. I think you got to go see this specialist, this provider. I hear from so many patients all the time and parents of young children who are having this happen. And I say to my orthodontic colleagues and all my dental colleagues, but especially my orthodontic colleagues, and a lot of times when I speak, I specifically speak to this. You have an opportunity here to literally transform human health as an orthodontist. And I don't believe that's being hyperbolic and I'm overstating it.
No, I don't either.
And I mean, ultimately, or do you just want to straighten teeth? And if you want to select the latter and just straighten teeth, there'll probably always be a place for people that just want to straighten teeth. That being said, I do feel hopefully in our sort of broader scope of medicine, we are trending in a direction towards more proactivity with podcasts, with people like Peter Attia and books like Outlive and things about getting at the root causes of these things, looking at the etiology versus just treating the symptom. So I'm struck by what you're saying, in that I feel like that is a big obstacle in the dental world to making progress in this arena, to people being more proactive. And then speaking as a patient who have had sinus problems and other issues, so I've had to see many providers over the years. Some providers, and even if you go with family members to a provider, they can't get in and out of that room fast enough. Oh. They're not taking time. You might get intake forms to bring ahead of time, but they don't even look at them. They'll ask you all the same questions that were on the form, or some of them. They won't see important points you highlight. So how do we break free from that system to get, before we kind of dig a little deeper into the why of what's going on in your findings, how do we get people to be more hyper aware of the importance of doing this? And does it come down to, I hate to be cynical, a reimbursement issue? Is it just because the system is built to not pay them, or us for sure in dentistry? We're not paid to diagnose, we're paid to treat.
Yeah. Well, the reason why I left medicine was because I wasn't getting paid for the things that I was doing, which was talking to the patient. And let me just parenthetically say, before I answer your question, what should we do? What I've learned that I need to do for all the lay people, or clinicians for that matter, who come to the dentist and come into this airway question or sleep question through the airway, and you want to do something in parallel like what I do, there has to be a way for you to refer that person with a support system that's big enough to help them, because you can't spend your time explaining all this to them. You're not going to get paid for that. Right. When we're going to talk about vitamin D levels, your front desk can't be reading their vitamin D results to them. The patients have to be willing to take responsibility for their own health in order to do some of the things that you and I want to do. Mm-hmm. And that means there's a subset that these interventions will apply to, and a subset that it's not going to apply to. Mm-hmm. And what I've learned over time was, I have to change the way I look at everything. I have to think of educating lay people. I really have to think of, what do they need? I've used business coaches who have changed my life because they are asking me, what do they need from you? Why aren't you providing that? Because I was not trained in that way for medicine. It's what's broken, let's fix it with this drug. And that's it. That was the whole story. And it really is. You mentioned that we've gotten fixated on imaging. Imaging is interesting and it's wonderful, and I'm glad it's there. But it does not replace listening to the person. And what I learned about back pain, I mean, there are a million different things going on when someone says they have back pain, and the imaging doesn't usually give the answer. It'll say very general things. So we've become fascinated by imaging and now by electronic devices and by electronic interventions. But the curiosity that you've expressed, that I had, what if I were sitting in this chair and saying those things to me? Changing the dialogue so that we are both the patient and the clinician are on the same level. The same caste system that we mentioned before is hurting our ability to get to the patient. So yes. I really think that you are doing what we need to do. You are here with me. We are talking about things that are so common, and the patients are frustrated. The clients are frustrated by having a human being promise to be with them. Being with them means holding their hands virtually or physically while they're going through this experience. And what I learned when I stopped being so arrogant was they don't really expect us to know everything. They know that we're struggling too. They know that
they appreciate the honesty. I find they appreciate the honesty.
They love that honesty.
Yeah.
And that means I don't know why this is happening to your daughter, but together I will help you try to find out.
Right.
Is a very welcome answer. They just want somebody to try to help them. And I think more and more, the last generation for sure is not unwilling to say, I'll go look up, if you'll tell me the direction, I'll go look up stuff too. And I get articles. What I thought when I started my own business, when I left medicine and started my own business, I thought I had a fully packaged presentation that I'd written an article about. And then I started to lecture to the dentist, and I would be sitting in the back and going, oh my God, he's really talking about me. I wonder if I have a small airway. And I didn't know anything about this. And change it, things that I can see on movies where little kids have really bad facial development and big black dark circles under their eyes. And I'm like, oh my God, you know what? These are both happening in parallel. My whole attitude then after that experience, even a couple of lecture settings where I'm, oh man, this is really just as important as what I'm doing, means that you open your mind to the fact that we're all trying to go along the same path together. And we all have things to actually contribute. And now what I look forward to is I have learned so much from all of the people that I've touched who send me articles. There's no way I would ever know that, B5 is used as a transmitter in the colon by this particular bacteria. And that B5 hits a receptor that then goes into our body and tells us whether or not we want high-fat, high-calorie food or carbohydrates. Because somebody sent me this article. They said, oh, I know you're interested in B5. They sent me this article and I'm like blown away. So I think you're doing what we need to do. It's so slow that you and I are frustrated beyond belief.
Facts. It is hard with the speed of it. I do see progress. I do see it trending in the right direction. I agree with you. I want to make sure we have time to get to a little bit more of the science on, or at least the clinical presentation and symptoms and then processes that you take to break this down in your patients when you're seeing these patients who are suffering.
The first comment I would have is I'm going to shorten things a lot in how I arrived here.
Sure.
Because there are many other interviews that talk about the mistakes that I made and the bad outcomes. The bad outcomes with your patients are just as important or more important than the good ones because they tell you that, oh, that direction isn't the right way. Ultimately, vitamin D is very important in everything about our body. It is very important for sleep. It has direct effect on sleep. But at 2 years of learning about dosing, learning about keeping vitamin D levels where they need to be for better sleep, we all failed in a really ugly way with lots of pain of various kinds.
So these patients, you're saying
my patients
stopped.
were myself. Okay. I was doing the same thing they were. I'm perimenopausal. I'm in my 50s. I'm not sleeping well either. My D was 35. So I'm doing the same thing they are. And I really thought I'd stumbled into the answer for everything. But in 2 years, we all started to fail. I personally had this weird buttock pain where I couldn't sit down at the end of the day. I mean, what a weird experience. I hadn't fallen. I hadn't hurt myself. I had this whole set of ideas that had to do with why would we get paralyzed? Why would we paralyze our limbs? Is it possible that that guy with the 4 failed back surgeries never gets paralyzed? Therefore, whatever the surgeon does doesn't actually heal. And all the best they can say is he has 4 failed backs. No, we have to be, there's a reason why we're paralyzed. It's dangerous to be paralyzed. We're quite vulnerable. And so that's what I was thinking. But then the vitamin D failed in terms of making all of us better. And then a patient brought me a book. The reason why she brought it was about B5, which is pantothenic acid, which is also an overlooked vitamin. All of the textbooks say pantothenic acid deficiency doesn't exist because it's in every food. It's one of the 8 B vitamins. And I had no knowledge of the B vitamins, nor did I want any. But I knew the B12 was helping my patients. So it was very confusing. I had already been scared to death by D and the potentials of doing something that would make my patients worse. So she brings me this book because the woman is treating rheumatoid arthritis. She herself has arthritis. She says pantothenic acid at 400 milligrams a day helps the pain and it helps them sleep better. So she brought it to me because she knew I was a fanatic about sleep. And then I went down this very complicated road of giving 400 milligrams to my patients. None of them could sleep. They immediately became insomniacs and only took it for 2 days because they got so revved up, they couldn't settle down and they couldn't sleep at all.
Wow.
Which is really creepy. And I personally started the same amount that they did. And by accident, I also took something called B100. The big problem is now we step into the world of supplements. There is no one really running the ship. Yep. Vitamin D, and unfortunately, is classed with the vitamins. The difficulty of that is that the doctors don't know about it, and they are now currently being instructed not to learn about it, which is bizarre. And it's been grouped with vitamins. The good part is it's available over the counter. That means we have forced our patients and the rest of the public to actually relearn what we've taught them, which is incorrect. So the supplement world is telling us all sorts of things that is absolutely wrong. And the reason why I know that is I got to see myself and other people fail, not be able to sleep at all. It's clear that B5 is powerful in sleep. But if you get the wrong dose, and all of a sudden it's the opposite effect. And that is the case for all of these chemicals. Our body is always in the homeostatic middle. That is not the way we've been trained about vitamins. For reasons that are not completely clear, but so I fall into the B vitamins, and right off the bat, I realized that you can't look at the front of the bottle. You have to look at the back. At the time, I didn't even know how many Bs there were. But after a while, I'm looking through all these Bs, and I finally get to B100. And miraculously, I am taking B100 and 400 milligrams of B5. My sleep was unaffected, but I have restless legs. And my restless legs got worse. So within 5 days, I knew that this was the wrong dose. But I had given out that recommendation to about 30 or 40 people. I didn't know what was going to happen to them, but I thought this is going to be like the D, where there are all these things that are written in the literature and they're overtly wrong. So then I take B100 and my butt pain goes away in a day, which is also ridiculous. And the only person I would ever say that to is someone else who's my patient, who comes back within the next 2 or 3 months and says, that 400 milligrams made me really sick. I felt terrible, couldn't sleep at all, and I was agitated. I couldn't settle down. And they all use the same phrasing. Like, what is this doing sitting on the shelf? That was the only dose of pantothenic acid available, 400 milligrams. Why is that sitting innocently on the shelf? What is different about my patients that they have the opposite to this woman who wrote this book? Vitamin D, that's the only thing that's different. They have taken vitamin D for 2 years. Something changed biochemically there that made they clearly, it has a power in sleep, but the brain wants a certain dose. The other thing is, we're taught the vitamins, you can't hurt anybody with vitamins. Well, that's wrong. That means the people who are using these energy drinks, they're using them because they feel that they give them energy. That means that their original state was a deficiency state where they can feel better when they take the B vitamins. Not just caffeine, but the B vitamins are frequently there. The other
right. Interesting. Yeah. It's amazing, by the way, and alarming, having teenage daughters. And we were just talking about this with my younger daughter and her friends, how many of her friends are on these energy drinks. I mean, they live on them. We barely drank coffee when I was in my mid-teens. Exactly. It wasn't until I went to college, and you got to stay up a little later maybe for a test. But I mean, there to be that, I guess the right word is addicted to these energy drinks where you need one every day.
In the chemical that allows them to concentrate.
Oh, interesting. So it's not just the caffeine.
No, it's not the caffeine. Okay. And if you give it to somebody who's done the right sleep program and their microbiome is back and their D is good, they will be so wired that they'll freak out and not have it anymore. That means that you can take these vitamins and feel the effect immediately in a half an hour. Now, I have to say, as a biochemist and a physician, that creeps me out.
Yeah.
Because so what I was hearing from them is what I would hear from someone who I gave, an ADD medicine, which is actually a dextroamphetamine. I'm giving them an amphetamine. Well, wait, this is a B vitamin. Why would it be acting like an amphetamine? This is crazy. It's not what I expected. And then over time, I've got 30 people telling me exactly the same thing. And then 2 of them who had burning in their hands and feet, 2 women, nothing to do with each other, both have headaches, don't have diabetes, already on B12, which is one of the things that treats burning. Immediately, in 2 days, the burning is gone. And there's literature mentioned, the references that made me brave enough to do this were from the 1950s. So there were actually experiments where they took out B5 totally out of the food and produced 4 things within 2 weeks in convicts where they tube fed them. So they had not been repeated. They had gait disorder, insomnia, belly complaints, and burning in the hands and feet. And I just produced that. Now, the creepy part is I produced this in 100 people by taking D continuously and improving their sleep. My concept was I was going to improve their sleep and not just put them to sleep. That's what we do with sleeping pills. We are going to encourage the brain to make repairs. Therefore, I am actually, in my intent to make them better, I have driven them into a B deficient state. Why would that happen? None of them have changed their diets. We are told if you have a good diet, you cannot be vitamin deficient and you don't need vitamins. And that is clearly belied by this experience with all these people. And I give them back the vitamins and everything goes away, boom, like in a day. So I had that experience and was afraid to tell anybody because they already thought I was crazy with the D stuff. But my patients came back and said the same thing. You know what's weird? I stopped at 400 milligrams and then I took just the B100 and all my pain went away all my joint pain went away in about 15 minutes to 30 minutes, and then it would come back later. So there are all these experiences where patients are telling me things, and I'm like, what do you think's going on? That's what happened to me. How can we explain this? This is crazy. And then several years pass where I'm learning what to do with this. I have no explanation. And I'm telling them things like, this stuff will act like caffeine if you're on too much, okay? But I don't really know what the chemistry is. And then I'm about to give a lecture that I'm worried that they're going to film it because this is way back in 2013 when I'm not used to the idea that somebody's going to film this and put it on YouTube without even telling me. And so I think I better look this up. So what happens is I put in, pantothenic acid. What's this about in the brain? Well, the literature up until now was that pantothenic acid made coenzyme A Coenzyme A made cortisol. It was necessary to make cortisol. There are a whole bunch of articles from like the 60s and 70s after those convict experiments where they recognize that, prednisone helps rheumatoid arthritis and lupus. So we make prednisone, we see that it's like cortisol, and they actually do a bunch of vitamin experiments where they're giving pantothenic acid by itself. The problem is they're not just pantothenic acid deficient. It turns out D is the first domino to fall, always. The D falls, D runs the microbiome. The microbiome supplies the 8 Bs. That's why there are 8 of them. And somebody knew this in the past. I haven't found the article that talks about it, but just like the stuff you were talking about in orthodonture, there's a reason why there's vitamin A and then 8 Bs and then C, D. Like, what? They all come from a foursome of bacteria that, oddly enough, develop spontaneously. If you ever made bread or beer, what you do with it is you leave it in an open container. You put yeast in it. Yeast makes D2. The bacteria are not picky. We don't use D2, but they do. The bacteria from the air and the water, it then selects for certain bacteria who like D, and they start to multiply. This is the background to fermentation for beer and for bread. That was the original thing that was used. You pour it, all of the current Petri dishes have a yeast extract that they put in there because it was historically needed. So it turns out that the B vitamins are all generated by the bacteria that are growing in the Petri dish, just like this current trend in fermented foods. What you're really doing is you're eating rotting food. Well, one of the things that we've started to do since the last 100 years is to run away from rotting food. In fact, we have food that's been washed 3 times. So there's a talent and an experience to learn how to rot foods without hurting someone. That rotting food is actually building the secretions of the bacteria, and then you are drinking or eating it. So all cultures have these fermented food that we have historically eaten, and we used to eat food that had mold on it because we didn't have any other food. And as we went from a time when D was not low, so probably when the medicine said in the late 70s, if you have a normal diet, you don't need vitamins, the minority had an abnormal microbiome. And then as the D became more and more epidemically low, it is not antibiotics that ruined our microbiome. That's what we're told, but it's not true. It's the low D that ruined it. And that only first article in humans came out in 2020. So that's a relatively recent proof. But one of the reasons why we don't know much about the microbiome bacteria, we have names for 200 or more. We have the DNA of 200 or more. But we don't know how to grow them in a petri dish because we missed the fact that D is a growth factor. And it's a very important selective growth factor to certain guys. And that is how a baby generates his or her own microbiome from mom's breast milk. And the breast milk has the B vitamins that she's feeding to the baby that come from her microbiome, not from the food she eats. So it happens that I fall into this connection between the D and the microbiome at a time when nobody's arguing with me when I say, oh, your microbiome is hosed, and that is the source of the B vitamins. All I had to do was read the articles and go, wait a minute. If every single one of these Bs comes from the colonic bacteria and a food source, why don't they just get brave and step up and say, hey, they're not coming from the food. It's true that it's important what you eat. Absolutely. That doesn't mean it's not important, but you are feeding the bacteria and then they are feeding you. Regenerating the microbiome. So the reason why I have a website is I am terrified by the idea that everybody who started taking D in COVID would then 2 years later, like my dentist's wife has chronic COVID. She has long COVID. She hasn't gotten out of bed for the last 4 years. And he tells me things like, we were going to retire and we were going to do all this traveling. And now I don't even want to be at home because she's so uncomfortable and I don't know what to do to make her better. All of these things that we started, and you don't even have to continue to take the D. Once your body has started to see D, it has started to try to make more repairs, you have become B deficient and your microbiome is not supplying it. And everyone around you has a name for what you have. You either have rheumatoid arthritis or you have terrible heart disease, like, your heart's just failing when you're 32 years old. We'll have to give you a heart transplant. And it must be a virus. They're just giving you names for things, but they're not reversing it. And this particular little wedge, especially B5 deficiency, the articles in B5 deficiency were completely gone until the last 3 or 4 years. And in the last 3 or 4 years, there's a little uptick in finding B5 deficiency in animals and in humans, and finding B5 deficiency in Alzheimer's disease brains, and in Parkinson's disease brains, and in Huntington's disease brains. Because we wrote this stupid dogma, B5 deficiency doesn't exist because it's in every food, those of us who want to stay in the lines, stay coloring in the lines, and be good little humans that do what our mentors told us, would say, well, there isn't any B5 deficiency. Well, I'm sorry, when it's staring you in the face and you know that burning in the hands and feet is not something that you've seen, neuropathy is my subspecialty. That burning in the hands and feet was not common. It's common now. And I have people who present with burning mouth after they did COVID D for 3 years, and then they stopped the D. And oddly enough, where does it show up? Often at the end of the summer. Because they're not on D now, but they're out in the sun. They're 40 years old, more and more sun exposure, their D goes up. That increase in D makes their body need more B5, and they're not making enough because they don't have the right bacteria.
Okay, and that's actually, that was what I was going to wanted to parse out, is that's sort of the sequence is, again, I guess you could just comment and highlight, maybe underscore a little bit of the difference between the natural, the sunlight-derived D3 that we're getting, the sunlight-derived D vitamin that we're able to synthesize and use for our metabolic processes, of which there are so many, and you named ones I hadn't even been remotely aware of. And then the supplementation D3, let's just say it's D3 and not D2, and then how those interplay with B5 specifically, with the B vitamins, and then how that interplays with the microbiome. I know that's a lot, but is there kind of a flow almost that you could, a picture you could paint for everybody of that?
It's a flow that we're never going to really discover, because medicine is being told that vitamin D should never be tested. Like the endocrine system. Yeah. What our patients are getting now is the endocrine society. Here's what the endocrine society said, and then I'm going to come back and answer your question. This is a hormone. This is a hormone that's made when we're outside. Yes, it's true that you can eat salmon vitamin D, but that's not salmon's vitamin D. Mm-hmm. You can eat salmon that has estrogen in it. Does that mean you don't have to make your own estrogen? And by the way, if it were really a nutrient, none of us would be deficient. So calling it a nutrient, calling it a vitamin, and ignoring the fact that the only way that you can make it in its natural form is to be outdoors, means that we have just really screwed up. Now, in the background, there's so much to learn about there's a rainbow of types of D that are made on the skin, and similar chemicals that have similar effects on fibrosis, scarring, preventing skin cancer. There are already a set of chemicals that are just being described in the last 5 years that show that our body was actually protected by these chemicals that we make when we're out in the sun. We're meant to be out in the sun. And in fact, pay attention to the fact that we're bald. There are very few animals, except for domestic pigs, that are fully bald like us. It probably gave us an advantage of some kind, probably meant that we can make more D. There are some things about it that are unique and allowed us to beat out the other hominids that were walking around, okay? Now, that means that taking this stuff in the little golden balls that I'm still using is not the same as being outdoors. There are many other wavelengths of light that actually infrared penetrates our body by several centimeters and is integrally related to our biology. So your question actually leads us over into an area that is quite complex and just beginning, which is energy is conveyed by the sun. And that energy has always been used by all living things, just like plants. That means those energy wavelengths that are only being recognized by medicine as woo-woo stupid stuff because we're saying you can't hold your phone to your head, that is a problem perhaps, but the bigger question is, what have we done to our biology by going indoors as much as we have? And then seeing it through that lens so that you say, oh, the Mediterranean diet. The Mediterranean diet actually happens in a population that walks stairs up and down their whole life into their 70s and 80s, and they grow their own vegetables, which has to be done outdoors. So there are ways to look at this through a completely different lens that ultimately all I have is to say you need to be outside more. You even go outside when you're not in the direct sunlight. You must respect the fact that you should not burn your skin because it's bad for you. But everything else that you do, it's better to be outdoors. And
without sunscreen, you're saying as long as you're not going to have an extended exposure where you burn, sunscreen can prohibit, right? The vitamin D side.
Sunscreen keeps you from making D. It may do a lot of other things that we don't even know about yet, but ultimately it's not bad to have sunscreen. Like everything else that humans come up with, it's not bad to have computers. They do all sorts of great things for us. You have to think of them within the proper context. So when humans and our pets are the only animals failing dramatically around the globe in the last 40 years, we need to look around and go, how come those squirrels look so healthy? You know, they're not taking the CPAP. That's crazy. Okay. So again, the lens that you look through is very important. So it's true that I'm biohacking with these supplements, and it is not easy and it's not safe. It never is. But what choice do I have? If somebody comes in with burning mouth and you get a story that they were on D for a while and you get a framework that supports the idea that they're doing this, and we can get that to go away, and then we can instruct them on not only taking these supplements, which will bring their microbiome back rapidly in context with D. This is something that I sort of have control over in a way that I wouldn't if they were taking cod liver oil or actually nutritional yeast, because then I don't know the contents, I don't know the dose. Those sorts of things are very helpful, but they are never the whole answer. And there are always there are a bunch of other deficiencies that are in the background. And that's what we've learned over time is all the mineral absorption that we do of every single little mineral that we need, from iron to cobalt to whatever, those are all managed by the microbiome, all of them. Because the bacteria were here for billions of years before we came, and they were the original ones that figured out how to use a weird mineral in the middle of this enzyme and put a mineral within the context of a living thing. That sort of thinking is an evolutionary view, and that therefore it makes sense. Most people are not patient enough to listen long enough to get to that place. So they want an easy fix. And right sleep, in my view, even though it takes a year, 2 years, it's still a quick fix in comparison to what else we would do, which is to go outside and eat rotting food. Because my own experience with my patients is just doing D without the B50, without the B100, you are not going to get success. You're going to get burning, you're going to get rheumatoid arthritis, you're going to get bad outcomes 2 or 3 years later because your microbiome hasn't come back. It is my belief that eating rotten food was one of the ways that got the microbiome back when they got D deficient in the past. And that doesn't explain everybody on the planet. Okay, so there are people who live in Norway, in far north areas. And currently there are scientists that are exchanging ideas about how does the environment there change? How is it different? And what about the water they're drinking? And does it have less deuterium? And there are all these other questions that are being asked that are trying to address this, that are really weird sounding.
Yeah, and are there latitudinal changes in this? Can we look across different latitudes to see?
Yes.
Okay, interesting. A difference in patterns.
We're not going to get into that today because it's too crazy. But as a summary statement, what I have on my website with the Right Sleep program is a way for any layperson to first understand what they're doing. Okay, there's lots of free material on our website. if you see that it may have relevance to what your experience has been, and I do not recommend de-supplementation for anybody who's healthy. It is, if you're doing fine and you don't have any complaints, you do not want to be biohacking with something like a hormone where you're not measuring levels. So I teach you how to do levels. I teach you how to get them done. There are many self-ordering platforms now where your doctor can order them for you, but you have to know more about it. So I give you sort of the guidelines. First, I want you to be interested. If you are, then you get what's called the Right Sleep Program, which includes a workbook that tells you exactly what to do and when. And then you have a Facebook group that's other people who are doing it and have had success and are having struggles just like you are. And we have now 3 years worth of Q&A videos that answer any question that you might have. And one of the fascinating parts of this for me is that I keep learning. Other people are contributing things. And it turns out other deficiencies can develop over time.
Yeah, it's absolutely fascinating. I so appreciate you coming on and explaining that. I really do. I love it. I love the thinking outside the box. I just acknowledge you for pushing. I know as someone who has also been pushing colleagues, it's not easy. You take a lot of incoming. And I get asked a lot of times by people, they say, how do you deal with it? How do you deal with the hate or the blowback? And I honestly just say, because my purpose is so much bigger that it's just kind of part of it. And in a weird way, it almost tells me I'm on the right track and over the target, because if I weren't, people would just not even pay any attention to it.
I completely agree with you. That was beautifully said.
Thank you. I just feel that deeply. And I think there are some of us who are meant and called to spread this knowledge and this message and be able to not only spread it, but accept the feedback. And I feel I can speak for myself, and it sounds like in hearing and spending this time with you here, you're driven by outcomes and helping patients and making people healthier. And there is nothing like it. I say it all the time. My audience is probably sick of hearing me say this, but I love straightening teeth. I am blessed to be a very, very good tooth straightener. I did it for almost 20 years in my practice, and I'm very good at it. It still doesn't compare to when I would get that little one in and the mom, no one took the time to figure out why this kid had all these other issues. And they come to me because they just have a little open bite or something, is going on in the way they're growing, and the dentist sends them in, or maybe the mom is just a little concerned. And I distill it down and I look at a deeper level. And much like you, I don't have all the answers. That being said, I'm willing to look at this multifactorial etiology and say, maybe it could be this, maybe it could be this. And when you succeed in those cases and you transform the health and the lives of not only the children, but the family, there's nothing like it. It just motivates you to go out and be even more passionate about this. So I can see that in you as well as you speak and as you so beautifully and eloquently put these pieces together. And I also want to acknowledge that this isn't an easy journey for you. Like as you're talking, I'm like, my goodness, you start to figure out you have it in one sense and then it's not there. And the other thing too is I was struck by, I talk a lot, we go into it now as we're winding down, but the concept that Sackett had of evidence basis, which wasn't named until 1991 by Gordon Guyad, it's a relatively new phenomenon that is been used. And there was an article in 2016 by John Ioannidis from Stanford talking about the fact that it's been hijacked. It was a year after Sackett had died. And that evidence, think of what you're talking about. Part of evidence basis is patient values and preferences and clinical experiences and outcomes. And the third part is relevant scientific data and research. You have talked about all three of those things with relatively equal importance. You've referenced the literature many times. You've referenced what it means to the patient and how they're perceiving things. And you've referenced looking at your patients as a clinician. And I feel like so many times, if we just went back to the fundamentals of what evidence-based practice really is, it doesn't mean a randomized controlled trial that proves exactly what we want. I mean, if it were that, let me just, a little newsflash to everyone out there, orthodontics wouldn't exist because there are very few randomized controlled trials that literally prove almost anything we do in orthodontics. Uh-huh. So it is almost all convention and clinical evaluation. So let's put our egos aside. Let's realize that at the end of the day, our job is to practice, to get better and better and better, and do it with the intent to make our patients healthier. And you're doing it. And I just give you such credit for that. And thank you for coming on to share it.
Thank you. Thank you very much for asking me. My pleasure.
Yeah. Well, Dr. Stasha Gominak, absolute pleasure. At some point in the future, when you keep learning more about this, I would love to have you back on again to update us on where you are in your journey and your quest on the promoting the health span and health of our patients.
Okay. I'd be happy to do that.
I appreciate it. All right. Bye-bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.